Today we're on the couch with healthcare sociologist Dr. Peter Nugus. Peter works at the Centre for Clinical Governance Research at UNSW's Australian Institute of Health Innovation. Welcome, Peter.
Thank you very much, Steve.
Peter, you recently had a paper titled Selling Patients published in the prestigious British Medical Journal, and that was based on lengthy research and observations done in several of our biggest tertiary referral hospitals. It's been said that we've all got something to sell, and it seems that our doctors and nurses are no different. Tell us what you found.
There's an endless pressure on doctors and nurses to keep patients moved through the system very, very quickly, and in order to do that, they really have to sell them. And when I mean sell them, I mean they have to do exactly what you and I do when we try and buy or sell a house, or when we try and buy something from Harvey Norman. They need to do trade-offs, they need to minimise and maximise certain aspects of the case, they need to try and persuade the person to sell what they're selling, and that is a patient case. So they need to shape that case into what they believe the inpatient medical and nursing teams want.
Now, when we say selling, we're not talking about money changing hands.
No,
but
no,
we are
not that I
talking
saw.
about having to sell a patient's case to other doctors. So can you give me an example to explain what we mean by selling and marketing in a hospital setting?
Yes, absolutely. I mean, this is a fairly dramatic example. If a doctor, for instance, wants to persuade an after-hours medical registrar to accept care of a patient, they might minimise some aspects of that patient's surgical history. If for instance, they've had acute appendicitis in the past, they mightn't even mention it. They might just ignore that, but they might emphasise the respiratory and the cardiological and the renal conditions, because if they mention appendicitis, then that might be an invitation for the after-hours medical registrar to go, ring the after-hours surgical registrar. They've obviously got a surgical history.
But why is that important to actually direct the patient to the appropriate inpatient team? What's the politics involved?
Well, basically, what you've got is doctors and nurses. The job that they have in the emergency department is to try and transfer patients out. There's an endless queue of patients coming into the ED, so they've got to send them somewhere. The hospital's divided up according to individual organs of the human body, and that also matches the clinical expertise of particular departments. And so often it's quite clear cut. Somebody might have a presenting renal condition, so you ring the renal team, and the renal team would be very happy to take them. But increasingly what we're finding is, and what we found in our study, is that emergency departments are getting an increasing number of older patients with complex conditions and chronic conditions, and often there's a number of things wrong with them. There's they might have, one older person had about 12 conditions for which they could be hospitalised, and there's a power imbalance, and this is where this sort of game playing stuff and selling becomes very important, because there's a power imbalance in the hospital. An inpatient doctor will always have more power than an emergency department doctor because they know more about their particular organ, and they'll always be able to say, no, I'm sorry, the renal condition's is the primary presenting condition. Ring the renal team. It's not a heart problem. First and foremost. So those sorts of patients become more difficult to sell.
There are implications that come with this kind of discovery, that this game playing and strategizing and marketing actually does occur in hospitals. Can you tell us what those implications are?
Well, I think what it shows very broadly is that we've been very obsessed in the Western world with what's called access block, and that is the inability the inability to transfer patients through the hospital, to get patients discharged from the hospital, and to make beds available for people coming in from the emergency department. Then ambulances backed up. It's like one big carousel that keeps on moving. We've been treating this problem as a very technical problem, like looking at computational modelling, whereas what's called access block and emergency department overcrowding are actually cultural issues, they're social issues, and they're organisational issues as much as anything. And what this research has highlighted is that the patient pathway is governed by power structures and hierarchies and collective identities that work in the hospital. And that isn't to say that it's a bad thing, it's just to say that it seems that we're kind of in our infancy of looking very, very closely and ethnographically, and having someone like myself, wandering around with a notebook following, writing down what people say. It's in its infancy of looking at that as being an important aspect of healthcare, not just the biomedical side of things. And I think it's probably the case that most patients go to the right place with the right people at the right time, and the system is pretty much designed to do that. But I think that that's becoming increasingly less because of the complexity of the types of patients who are presenting. The real action is when you're trying to transfer the patient. That's where it happens, nurse to nurse, doctor to doctor, department to department. They literally psych each other up. They get on the phone, a junior will be on the phone, the senior will be standing behind, coaching them, say, right, practice, say it to me, before they're going to do it. The problem with it not being out in the open is that we don't kind of get criteria for fair bargaining rules, that sort of stuff. And I think the public needs to know that this is an important part of care. And I don't think it's the fact that it is necessarily a bad thing. I think it's we need to recognise care as being something that's organisational. I think that's why people like ourselves in the Centre for Clinical Governance Research, have an important role in researching healthcare, because it's you can't separate the clinical and the organisational sort of aspects of work.
And in your paper, you actually make a recommendation, perhaps a little bit tongue-in-cheek, that maybe this marketing, packaging and selling 101 could actually be introduced into undergraduate or postgraduate medicine programs. How serious is that suggestion?
I think it's quite serious. I think I think it's important for the organisational and communicational dimension of hospital and health life to come out into the open. I mean, there's kind of been a hierarchy of knowledge around healthcare, where biomedical or clinical knowledge is the highest form of knowledge, and some aspects of more social knowledge like communication have been co-opted, and they've been kind of siphoned off. So okay, we'll now introduce communication in the curriculum for medical students, and what communication really means is just two people talking, being assertive, etc., but pretending it happens in a vacuum. So these sorts of skills should be acknowledged and taught. Openly, I think, yes.
And you think there's still more work to be done?
Absolutely, yes. I think in emergency departments, I think, and in the rest of the hospital, the rest of the health service. And I think it's one of those things that if people sort of see the complexity of what goes on, I think people are going to be more forgiving and sometimes have more realistic expectations. And I think one of the major problems our health systems face is the fact that as a community we don't have the courage to ask and answer the hard bioethical questions about life and death. I think people increasingly have an expectation that the health system can fix everything, and it can't necessarily fix everything. And I think we're in the Western culture we're quite afraid of the concept of dying, and asking and answering important questions about life and death, and about what it really should be about, and how we ration our resources, because ultimately that's what we really have to do.
And some of it might also be taking some of the mystique out of medicine and what goes on in hospitals?
Well, I think that will actually help, because I think that will kind of democratise healthcare a bit, and I think, and I'm optimistic that the community would then sort of come to the party more when they can see that this is like a normal human system that's got its foibles, and that needs to be a human and a biological system all bound into one, and we understand it a little bit more and what these people are trying to do.
Thank you very much.
Thanks very much, Steve.